an interesting case which I would like to share today. Pyrexia of unknown origin, or fever without focus, or whatever you may name it, but approach is what I would like to discuss in this case. So let's start the case. So basically, we'll do is that yeah, I'm sorry. So I would like you all to sit with a pen and a paper, and I will go through what all we went through and we did, but it may not be right, and you may put your points or your thought process on the paper and see if you can reach the diagnosis early. So hi, my name is Dr. Khanjan Shah. I'm consultant pediatric intensivist and currently practicing at Sneh Children's Hospital, Ahmedabad. So to begin with, on 14th of February this year, symptoms for this 8-year-old girl started. Symptom initially was just fever. Apart from that, mild headache, no any other complaints whatsoever. If I tell you in brief about very genuine, down-to-earth parents, highly educated, and father had PhD degree in biochemistry, molecular diagnostic, and stuff like that. So basically a very good family. And on 14th, 8-year-old, their only child had a fever. So on 17th, they visited a nearby hospital with high-grade fever and they got admitted. So 8-year-old girl, 3 days of fever with high-grade intermittent with chills, no any other complaints. To complete the history, no significant past history. This is the only child, no recent travel or COVID. There's a history of TB to mother some 7 years back, and she was treated and asymptomatic since then. Birth history, immunization, growth and development, diet, everything was not contributed to anything. So how would you approach this child? So I would like you to pause at this point and write down 8-year-old girl, high-grade fever, mild headache. What are the possibilities? You can pause, and then once you are done writing, you can resume it. Yeah. So the referral unit admitted the child, and they did an investigation in CBC. It was hemoglobin was okay, counts were low, 63 poly and 21 lymphocytes, and platelets were also low, 1.4 lakh. CRP was normal, and they had sent a blood culture. So what do you think now the possibilities? We retrospectively thought it could be a viral, is what the picture looks like, and that's what the referral unit had also thought of. They repeated after 2 days. So now day 5 of illness. Now again, HB is fine, counts low, platelet low, SGPT normal, and dengue was negative as platelets and counts were low, which are rightly checked. Now what would you do? So on day 7 of illness now, and urine was checked normal, USG was on, which showed some mild splenomegaly. So this child was for 3 days admitted there. Investigation and IV fluid injection ceftriaxone was started. So if you would have done anything different, you can write down in the comment. Also, every time when I ask what's next or what's your possibility, I would like you to write down on the comment section below. So let's see who gets to the diagnosis early. So now on 21st, child comes to us with high-grade fever, and reason child was shifted to the RICU was that there was some saturation dipping which happened during fever, and once fever settled and that vasomotor disturbance settled, SATs were fine. So now if I tell you history, we digged into the history further. High grade intermittent with chills and rigor, now day 7, and interfebrile period used to remain normal. No complaint of cough, cold or throat pain, no complaint of abdominal pain, vomiting or loose stool, burning micturition, no complaint of weight loss, joint pain, rash, poor appetite, raw milk ingestion, no history of recent vaccination or travel. If you would like to ask anything, you can write down in the comment. I will definitely answer that. So this was the history of fever. On examination, vitals were normal, no icterus, no lymphadenopathy, no cyanosis, no clubbing, and general examination was also normal. Though USG had showed splenomegaly, clinically there were no spleen pulpable. So now this is what when we came into picture, and what are the possibilities you will think now. First blood culture has also come by now, which is negative. So you can pause, and now what would different you would do, or what we did, I'll just go through that. So our differentials were, first was the viral, so dengue, chikungunya, COVID was our first differential. Rarely HLH or MSC, typhoid and malignancy, just to complete the list. This was what we had because of the bicytopenia. We have thought of HLH and malignancy. Keeping season in mind, MSC and typhoid is differential any point of time in any PU in countries like India. So this was our thought process. So how to proceed? We admitted the child and we sent CBC repeat culture. We looked any other system involvement, dengue, chikungunya, PCR, COVID, RT-PCR. This is what we had sent. Vitals were monitored, symptomatic treatments, and ceftriaxone was continued. Now child was stayed with us for 2 days, and we waited for to look for the fever and any other symptoms to come. But no new complaints came, no new finding, but fever persisted as it is. So our reports on day 1 or day 7 of fever and day 1 of our hospitalization, counts low, platelets low, CRP was 12, COVID negative, urine normal, Vidal negative, dengue and chikungunya PCR negative. We did an X-ray, chest X-ray was normal, saturations were normal, no chest signs whatsoever. USG abdomen showed bulky spleen and some few subsymptomatic lymph nodes here and there. I don't know how much weightage one should give to this. So what next? Now you have a child, day 9 of fever. All common reports are, all common differentials you can think of has been done, and it is negative. Clinically, child fever persisted, pattern remained same, no change in frequency or intensity. And now there's educated parents started to get little restless. Obviously, any parent would, seeing the child being in sick and hospital for now 5 days or so, and still there is no change in the condition of child. So as if I have to briefly, so day 3 with us, but day 9 of the illness, same fever, no complaints. What clue we have is bicytopenia and some CRP here and there. Common viruses checked by PCR negative, malaria, X-ray, urine, and no any abscesses hidden in chest or lungs. So if we define PUO now, so PUO is defined the fever more than 38 degrees. So we had that. More than 8 days, we had that. And now the child in hospital, common disease being ruled out, and still we do not have diagnosis, is what the PUO is. So we could, we can say fever of unknown origin or fever without focus, that was the view. So once you know this, then our mentor used to say that once you have some handle, list down the causes, go through the books and see. So we thought, if you also, what are the possible causes? So generalized infections like salmonella, tuberculosis, viral infections, less common like brucella, lepto, and rare like enteroviruses, fungal, HIV, or another virus. So keeping the your geographical conditions. See, cat scratch I have not seen, but yeah, in India, commonly malaria, salmonella, tuberculosis, viruses is always on the top of the list. Localized infections like infective endocarditis, intra-abdominal abscess, liver infection, osteomyelitis, UTI. So, and rheumatological conditions like psoriasis, vasculitis, malignancies are also the differentials, and other miscellaneous causes, drug fever, factory disease fever, Kawasaki, MISC, etc. So list is long, almost 50 diseases are listed, but which one our child would fit into is what we had to do the exercise. So how would you go? So any approach to PUO, we have been taught that initially we think rare common diseases is common, so we check for them initially, be it CBC, blood culture, urine, X-ray, sonography, dengue, malaria, chikungunya, typhoid, and COVID, whatever the season and the current infections are. Then we go to the step 2 or tier 2 investigation, where we look for the rare diseases, relatively rare, I would say, brucella, EBV, HLH. Then we think of the investigations tier, we go a little higher, a little expensive test like imaging, and if there is any localization, we can definitely do those tests. Child has coughing, or we know that the focus most likely would be lungs, so we can do a CT early. But when there is no focus as such, you would go one by one. And lastly, we would offer the child to invasive and expensive tests like bone marrow, lymph node biopsy, PET scan, etc. So this is what rough approach would be to any PO, and that's what we had done. So now we checked for expert. We sent peripheral smear to be seen by an expert hematologist, and there were no blast or only reactive lymphocytes were seen. 2D echo was done to rule out infective endocarditis, to rule out any features of MIS-C or COVID-related complications and Kawasaki, stuff like that. So basically, coronaries, functions, everything was normal. Brucella, we had checked negative. EBV, we had checked, became negative. So now what? So now pause for a while. You have a child, day 10 of 9, 10 of fever, no any focus, chest X-ray normal, urine normal, dengue, chikungunya, COVID, malaria, typhoid, urine, USG abdomen, X-ray, echo, EBV, brucella, and a sort of malignancy by peripheral. So how would you proceed now? What extra you would do? So we sought the opinion of hematologist Dr. Anupa Joshipura, and we thought of whether should we do a bone marrow check for blood bone marrow culture, as well as for hemophagocytes, as well as for malignancy. But when ma'am saw the child was absolutely fine except fever, no glands, no liver, no spleen. So the parents were counseled that we are keeping malignancy on board. So we might wait for a day or two to go ahead with the marrow. If we do not clinch the diagnosis with other tests, we'll go ahead and do it. We checked for ANA, so rheumatological conditions that came negative. Then we thought of, we were not seeing what exactly happening. So to look for other viruses, we checked for multiplex PCR, and it checked this number of viruses and bacteria from the throat swab, and it was PCR based test, but it came negative. It's an expensive test. It's not routinely being offered or done, but in situations where there is a diagnostic dialing or you're not getting through to the diagnosis, we do this test, and we can do it from blood, respiratory, GI, depending on what primarily the focus would be. Then we had planned to do a CT chest, abdomen, and neck to look for any hidden abscesses or stuff like that. So at any point, if you feel that something else or something different could have been, now see, patient is with us day 4 and day 10 of illness. So that means now you can imagine the condition of parents, that they are very good people, highly educated, so they were understanding what we were going through and what we were doing. They have been counseled in depth multiple times about the approach, and they were okay with that. So CT abdomen was normal, no glands or anything. Neck was normal, and CT chest, no pleural effusion. Yeah, but now the CT showed subtle patchy areas of granulomas, haziness involving lung fields. There were multiple subcentric lymph nodes involving bilateral lung fields and green bud appearance, and few enlarged sub-centimeter sized lymph nodes involving right upper and paratracheal, left parietic, and subcarinal area. So now what would we do? So we again went through the tuberculosis history was there. So in India, what you would do? We would consider tuberculosis as differential when we see this. What would you have done? We did discuss with surgeon to biopsy the gland or whatever, but it was too small to get biopsied. No caseation, no OC. So we sent a sputum, sent once negative, sent twice negative. We sent a gene expert because of it being more sensitive, came negative. Did empty Montauk's test, it came negative. So all the tests which we could do to get the microbiological diagnosis for tuberculosis in from sputum and gene expert that had come negative. So what next? Now what would you do? Now you know that the reason of fever could be that lung lesion, which could be infective, inflammatory, or malignant. And how do you get to the diagnosis? So now they left in more than 10 days. So every family has one such person who would, come at this stage that they would say that things are not improving and we would like to take the child from this hospital to the other hospital. Father and mother were very convinced with our approach, but then the grandparents, and they came all the way from Uttar Pradesh in early morning in flight. They took the child in the evening and they went to their hometown. So on 21st, child came to us, and 27th, on 6th day after this thorough investigation and extensive going digging, go to the diagnosis. We could not clinch the diagnosis. We were about to go reach the diagnosis, and child went to their hometown in Lucknow. They said they would go to SGPGI or something like that. Now they went there on 27th of February, and from 27th till 4th they were there. Child continued to have fever. They visited multiple hospitals. Everyone had given them different options. Some were not taking kids, some were taking kids, but they wanted to start a tuberculosis treatment empirically. So father was not convinced. So on 4th of March, they came back to us again in Ahmedabad. So child came back. Now we were back to square one, 18 days of illness with fever as it is. Now new complaint which started last 3 days was coughing had started, and no any other features. Finding wise same, except now saturations on room air were 88, and child had to be started with oxygen for the first time in this illness. So we know that the disease is evolving. X-ray again showed, as you can see, there is worsening. So what next? How would you, now you know what the focus is? Would you consider doing biopsy, or what your thoughts? So I would like to see that in the comment section. Just pause it for a second and please write the answer in your comment. So again, we go through the causes, list of causes which would involve the lungs like this. So options we had either to do a BAL, repeat CT, lymph node biopsy, or bone marrow. We did CBC and CRP at that point. So platelet had improved to 2.76 lakhs, and WBC counts were also improving. So basically malignancy looked less, so bone marrow was out. So we thought of getting either BAL, and in the same setting we might consider getting a biopsy. That was what we had planned. But then when we sent a sputum this time, then this for the though the acid fast bacillus were not seen, but on gene expert they could detect T and microbial tuberculosis, and they found the sensitive it was. So basically the diagnosis, as we can generalize infection tuberculosis, it was a diagnosis. And what was new for us was that the fever pattern which this child had was little unusual. From very day one, high grade with chills with rigor is not that common in tuberculosis. Second thing, again, bicytopenia of this intensity is not something very common. Yeah, tuberculosis can have autoimmune thrombocytopenia and bicytopenia, but this was something unusual. And to get the microbiological confirmation, whether to start AKT empirically or not is always a dilemma. So diagnosis was pulmonary tuberculosis, and was started with anti-tuberculosis treatment, and she became REFFERAL on day 5, day 6 of starting it, became off oxygen and went home, and currently doing fine. So this was a case which I thought of sharing. Thank you so much for being with this, and do mention in comment if you like this case. Thank you.